Hello, my name is Dr. Julio Novoa. I'm a practicing cosmetic OBGYN from El Paso, Texas. Today's lecture will discuss the management of capsular contracture with high-profile and extra-high-profile implants. The discussion topics regarding this lecture will include the definition of capsular contracture, the causes of capsular contracture, the prevention of capsular contracture, and special considerations regarding capsular contracture with high-profile and extra-high-profile implants, including the non-surgical management of capsular contracture with these types of implants, as well as the surgical management of capsular contracture with high-profile and extra-high-profile implants. An additional caveat will include the association between dental caries and capsular contracture. The definition of capsular contracture. Capsular contracture is an abnormal response of the immune system to foreign materials which are placed inside of the body. In terms of breast implants, it is the most commonly associated complication with a rate of occurrence between 3 and 75%. I would like to distinguish the difference between a simple capsule versus capsular contracture. What is a capsule? When a breast implant is placed inside of the body forms a lining around it. This is the body's natural response to a foreign object. This lining, or capsule, is composed of an inner layer of fibrocytes and histiocytes, which are surrounded by a thicker layer of collagen bundles arranged in a parallel array. The outer layer is more vascular and is composed of loose connective tissue. However, if the body has an elevated immune response to the implant, the capsule can become thicker and will contract down around the implant, making it firm and irregular in shape. This is called a capsular contracture. The severity of the breast implant capsular contracture is defined based on what is called the Baker classification. And the classification is graded from grade 1 to grade 4. Baker classification grade 1. The capsule is not contracted and it is soft and thin and the implant is not visible and is freely movable. Patients without any complaints or problems are graded as grade 1 with a simple capsule. Grade 2. The capsule shows signs of contracture but is movable and the implant is not visible. The breast feels firmer than the opposite side. This is where patients start to notice there is a slight difference between one breast to the other, but really don't have significant complaints. However, the capsule becomes distorted by the contracture and the implant is squeezed out of its normal position and becomes visible as compared to the surrounding breast tissue. Grade 3 capsular contracture is where most patients will come in with a complaint of a distortion of the appearance or where there is a definite problem in the appearance of one breast as compared to the other. And grade 4 capsular contracture is the same as grade 3, but there is the addition of pain caused by the progressive tightening of the capsule. When a patient comes in with grade 4, the most common complaint is not only the distortion, but the patient is uncomfortable or suffering from pain on that particular side. The natural formation of the breast capsule. Under normal circumstances, the pocket remains open, allowing the implant to look and feel normal and move freely. Studies suggest that a capsular contracture is due to a sustained or chronic inflammatory or infectious response, allowing inflammatory cells in and around the capsule to exaggerate the production of scar tissue, causing a thickening and tightening or the contracture of the capsule. Causes of capsular contracture. The most commonly accepted cause of capsular contracture is associated with a transient germ contamination, where there is a contamination by bacteria around the implant shell which causes an inflammatory reaction, thus leading to the shrinking of the capsule. Number 2 is seroma, where pockets filled with serosal fluid around the implant cause an inflammatory response which can form after surgery. Hematomas. Hematomas are pockets of blood-filled fluid, often due to bleeding after the formation of the original implant pocket. The retention of retained blood or clots can cause an inflammatory reaction, which again lead to a capsular contracture. Smoking. Smoking, specifically the inhalation of nicotine, causes a decrease in the oxygen levels in the blood, which can result in delayed healing and possibly an inflammatory reaction. Postoperative infection. Capsular contracture has been found to be more likely following an infection of the breast pocket and adjacent tissue. Trauma. Postoperative injuries such as blunt force trauma from domestic violence or due to an automobile accident can produce an inflammatory response during healing, leading to a capsular contracture. Radiation treatment for breast cancer. In the cases of breast cancer treatment and reconstructive breast surgery, radiation, which is intended to kill cancer cells, has an indiscriminate negative effect on healthy breast tissue by causing a decrease in blood supply, a decreased rate of wound healing, an increased risk of wound breakdown and extrusion, and an increased risk of fat necrosis. The true cause of capsular contracture remains elusive. The causes appear to be multifactorial. However, there are two prevailing theories regarding the cause of capsular contracture. Number one, the infectious hypothesis, and number two, the hypertrophic scar hypothesis. In the infectious hypothesis, a subclinical infection produces an inflammatory response. There is a possible formation of biofilms on the implant, allowing for the colonization of a stable bacterial matrix. What is a biofilm? A biofilm is a highly hydrated extracellular matrix, or slime, allowing for bacteria to cluster together on a surface, such as the implant. Depletion of metabolic substances, or waste product accumulation, causes bacteria to enter into a slow or non-growing stationary state. Therefore, biofilm microorganisms are up to 1,000 times more resistant to growth-dependent antimicrobial agents than their free-living counterparts. The existence of a biofilm represents a basic survival mechanism by which bacteria resist against internal and external environmental factors, to include antibiotics and the host's immune system. In the case of the hypertrophic scar hypothesis, a non-infectious stimuli such as glove powder, towel lint, airborne particles or dust, hematomas, granulomas, and hereditary factors produce a foreign body reaction and resultant formation of a hypertrophic scar. The underlying mechanism behind this process involves the activation of myofibroblast cells within the capsule, and these cells are responsible for the contractile forces which produce the capsular contracture. Myofibroblast cells contain the contractile elements actin and myosin. However, in capsules, these cells are found sporadically detached from one another and in very small quantities. In this scenario, these cells do not appear to possess the necessary characteristics to produce a contracture. In comparing the infectious versus the hypertrophic scar hypothesis, current evidence supports the infectious hypothesis over the hypertrophic scar hypothesis as the cause of breast capsular contracture. Prevention of capsular contracture. The literature suggests the following. Number one, the use of cohesive gel implants appear to reduce the risk of capsular contracture as compared to traditional saline or silicone implants, with saline having a reduced risk of capsular contracture as compared to traditional silicone implants. Number two, the use of textured over smooth implants. Number three, the placement of implants in a submuscular as compared to a subglandular plane. Number four, the use of a no-touch technique to reduce the risk of bacterial contamination during the initial surgery. Number five, the postoperative use of massage and compression therapy to soften the pocket and massage the breast. Number 6, the prophylactic use of antibiotics preoperatively and postoperatively. Number 7, the prophylactic use of Aricept OR. Number 8, the prophylactic use of leukotriene inhibitors. Number 9, the prophylactic use of steroids. Number 10, the postoperative use of vitamin E, milk of thistle, and omega-3. And in special cases to include reconstructive surgery, repeated capsular contracture management, or in thin patients, the use of grafts. Studies suggest that silicone implants have a higher incidence of capsular contracture as compared to saline implants. The use of textured over smooth implants. Compared to smooth implants, textured implants appear to have a lower risk of capsular contracture. For example, Allergan Style 410 implants, which have a high three-dimensional textured biocell shell, have a lower rate of contracture as compared to smooth and less textured implants. Submuscular implant placement. Complete submuscular, partial subpectoral, and dual plane implant placement reduces the risk of capsular contracture as compared to subglandular or submammary placement. Why submuscular over subglandular? Implants placed over the muscle or in a subglandular plane come in contact with the breast ducts, which are known to harbor bacteria, which increase the risk of both subclinical and clinical infection. The greater the coverage by the pectoralis muscle, the more protection. Therefore, complete submuscular implant placement potentially provides the highest protection against contracture. The no-touch technique. Skin bacteria contact of breast implants is considered to be a significant cause of subclinical infection, leading to a subsequent symptomatic capsular contracture. Many surgeons employ a no-touch technique aiming to lower capsular contracture rates by eliminating skin contaminants. One approach requires several assistants to hold retractors so that the implant can be inserted into the pocket without touching the skin. Others have adopted a no-touch technique, which uses a sterile tube or a simple anoscope acting as a sterile sleeve. A very popular device, especially when considering the placement of silicone implants, is the Keller funnel, which is a disposable cone-shaped device with a special hydrophilic interior coating allowing for a no-touch placement of silicone implants, especially large silicone implants. Massage and compression therapy of breast implants. Massaging and/or wearing a compression garment or bandage may help reduce the incidence of contracture. Repeated pressure on the implant causes expansion and stretching of the capsule, reducing the risk or degree of the capsule hardening or shrinking. There is a special exercise called a floor compression exercise where the patient rests directly on her breast while on her hard surface for 1 to 2 hours per day. This causes the implant to expand along its lateral borders, keeping the pocket open and stretched. There's also the bed compression exercise, where the patient rests on her breast directly while she sleeps in the prone position. Although both bed and floor compression exercises can reduce the risk of capsular contracture, repeated pressure on the lateral margins of the implant can lead to pocket failure and implant malposition, especially when using large, high-profile implants. Prophylactic use of antibiotics. As repeatedly stated, capsular contracture may be associated with subclinical bacterial contamination from skin flora. To reduce this risk during implant insertion, the use of prophylactic antibiotics, especially against staph and strep, is recommended 3 to 5 days before surgery and up to 7 days following surgery. It is also recommended that an antibiotic irrigation protocol be used during the placement of the implants, which in most cases includes a combination of bacitracin, Ancept, and gentamicin, and a 500 milliliter dilution of normal saline. The combination of pre- and postoperative antibiotics has been recommended to reduce the risk of staph and strep bacteria, especially staph epidermis. Preoperative and postoperative antibiotics include Augmentin and Cipro. Prophylactic use of Irricept OR. Irricept OR is an FDA-approved cleansing and debridement system containing chlorhexidine gluconate in a sterile irrigation solution. It provides broad-spectrum coverage against a variety of bacteria and fungi to include MRSA and Pseudomonas. Irricept is known to destroy or inhibit MRSA and coag-negative staph growth on lab samples for up to 14 days. Staph epidermis, which is a known skin contaminant and one of the most common associated causes of capsular contracture, is a coag-negative bacteria. Irricept OR alone, without antibiotic irrigation, is also a viable substitute to triple antibiotic irrigation. Prophylactic use of leukotriene inhibitors. Leukotriene inhibitors, aka leukotriene receptor antagonists, or LTRA, are prescription medications used to treat asthma and some allergies by blocking the formation of leukotrienes. Leukotrienes bind to cell receptors and initiate the chain of events leading to symptoms of allergy and asthma. Currently available leukotriene inhibitors include MONTELUKAST, ZAFIRLUKAST, and Xylutin. Both MONTELUKAST, also known as SINGULAIR, and ZAFIRLUKAST, also known as ACCOLATE, have been recommended for the off-label prevention and management of capsular contractures. ACCOLATE is a synthetic peptide that inhibits the receptor binding sites of three leukotrienes, LTC4, LTD4, and LTE4, that cause smooth muscle constriction. It is used for mild to moderate persistent asthma, exercise-induced asthma, and the management of allergic rhinitis in those ages 7 and older. It is also recommended for the prophylactic care of patients considered high risk for the formation of capsular contracture, as well as recommended for the non-surgical management of capsular contracture and for the post-operative management of capsulectomy. Question: if the risk of capsular contracture is listed to be between 5 and 35%, why aren't all patients considered to be high risk? Per our protocol, all patients are advised to begin using ACCOLATE following augmentation regardless of risk. The dosage is 20 milligrams PO BID times 3 months, beginning 24 hours after their surgery. ACCOLATE is considered to be generally very safe. There are rare cases of eosinophilia, eosinophilic pneumonia, and vasculitis. There is also the increased risk of causing elevation in liver enzymes. Therefore, it is contraindicated in hepatic disease. MONTELUKAST, also known as SINGULAIR, is also considered to be very safe. It is the only leukotriene inhibitor that has been approved by the FDA for use in children as young as 2, as well as for the treatment of seasonal allergies. Its dosage is 10 milligrams PO Q day times 3 months. Based on the high incidence of capsular contracture following breast augmentation as documented in the literature, we consider all patients to be high risk and therefore strongly recommend the use of either ACCOLATE or SINGULAIR for the prevention of capsular contracture. In our case series of over 650 patients using ACCOLATE, we have not seen any adverse effect with its use. Therefore, we recommend that patients be started on either ACCOLATE or SINGULAIR beginning 24 hours following breast augmentation surgery and continuing for 3 months. Prophylactic use of steroids. Prednisone beginning 2 weeks prior to surgery has been recommended for the prevention of capsular contracture. There is no established dosage, however, for the use of prednisone in this particular situation. If use is based on the anti-inflammatory effect, the dosage used in other diseases such as COPD or anaphylaxis, which is about 40 milligrams per day, may be considered. The intraoperative and postoperative use of a variety of steroids, such as triamcinolone acetonide, most commonly known as Kenalog, prednisone, and prednisolone, have been recommended for the prevention of capsular contracture. The risks versus the benefits of prophylactic steroid use is dose-dependent. When given prior to surgery or intraoperatively, steroid-induced impaired wound healing, risk of infection, skin and adipose tissue atrophy, also known as blue window syndrome, dehiscence and extrusions are possible. For example, information provided by the American Society of Cosmetic Breast Surgery, based on some of their work, showed that the use of Kenalog, which was injected with 20 milligrams per side into a double lumen gel saline implant, produced up to 50% blue window side effects. These side effects were seen to resolve once the steroid wore off or was washed out of the pocket. Prophylactic use of ultrasound. Ultrasound therapy, beginning 1 day to 1 month following surgery, has been found to be helpful in the prevention and management of capsular contractures. There are 3 theorized effects related to ultrasound therapy: mechanical, thermal, and biochemical. The mechanical effect appears to produce micro-massages, improving lymphatic drainage and edema. The thermal effect increases speed of cellular metabolism, activates fibroblast production, helps the healing process, and improves scarring. While the biochemical effect improves vascular proliferation, increases tissue oxygenation, increases release of cellular mediators, and increases fibrolytic processes.